Hello, I am Dr. Sindhu. I am a surgical oncologist at Gleneagles BGS Hospitals. Uh, Today, our Facebook Live session is on the advances in cancer surgery. So, before we proceed to the advances in cancer surgery, I would like to give you just on surgical oncology per se. So surgery plays an important role in the management of cancers, and it is the primary treatment modality for a variety of cancers. Decades ago, surgery was for cancers was very aggressive, radical, and also had an inferior post-surgical quality of life. However, currently, surgery is more precise and with less trauma to surrounding structures, minimally invasive, and also improves the patient's quality of life. So having said that, I'll highlight a few of the advances in surgical oncology over the past several years. The first one that I would like to tell you about is what we call organ preservation surgery or organ conservation surgery. So, like the name suggests, here it is a specialized surgery where the part of the organ harboring the tumor is removed, saving as much of the healthy organ or tissue as possible. So, doing this helps in improving the post-operative functional outcomes, especially physiological functions such as speech, swallowing, limb movements as well. So this organ functional preservation surgery is done in a variety of cancers, and such as in breast cancer, we can do a breast conservation surgery instead of a mastectomy, which improves the aesthetic aspect of the surgery. And in laryngeal or voice box cancers, we can do a partial laryngectomy to preserve the speech and swallowing. In rectal cancers, we can do a sphincter saving surgery, which helps or avoid the permanent colostomy. So, a permanent colostomy is when part of the colon end is brought out of the skin and a bag is connected, colostomy bag, which collects the fecal material. So, this can be avoided in certain early stage cancers by doing a sphincter saving surgery. And also in bone cancers, we can do a limb salvage surgery where we preserve the post-operative limb movements. So this organ preservation or conservation surgery also minimizes the psychological impact on the patient. This can be done only in early stage cancers, which is why it is also very important to get any new persistent symptoms evaluated by your doctor. Organ conservation surgeries have a quicker recovery and also lesser post-operative complications and morbidity. The second advancement that I would like to tell you about is what we call minimally invasive cancer surgery. So this minimally invasive cancer surgery includes laparoscopic surgeries, robotic surgeries, and also endoscopic or natural orifice surgeries. So laparoscopic and robotic surgeries are done by small incisions, and in laparoscopic surgery, specialized instruments and cameras called laparoscopes are inserted through these small incisions into the abdominal cavity, and the tumor is resected with minimal trauma to surrounding structures. In robotic assisted cancer surgery, we use the help of robotic systems which provide us with 3D high resolution images and also help us to resect tumors with more precise surgeries and also with improved dexterity. Both laparoscopic and robotic surgeries are usually done in gastrointestinal, gynecological, and urological cancer surgeries. We have the endoscopic or the natural orifice surgeries, which are done in very early stage head and neck cancers. And all these minimally invasive cancer surgeries have smaller incisions, so lesser postoperative pain and lesser postoperative complications, and therefore a quicker postoperative recovery period. Also, a shorter hospital stay and a quicker return to regular life and work. However, this minimally invasive surgery cannot be done for all patients, and certain advanced tumors as well as emergency settings may require an open approach. The third advancement that I would like to tell you about is what we call CRS with HIPEC, and also another entity called a PIPAC. Now, the CRS with HIPEC is basically a procedure which is indicated for peritoneal carcinomatosis. So first, what is this peritoneum? The peritoneum is the inner lining of the abdominal cavity. So certain abdominal cancers such as the ovarian cancer and certain gastrointestinal cancers can spread to this inner lining in advanced stages. And also there are certain cancers which can arise primarily in the peritoneum called peritoneal mesothelioma. So these cancers which have spread to the peritoneum are very difficult to manage with our standard chemotherapy regimens, which is where the CRS with HIPEC comes into play. So this CRS with HIPEC is the treatment of choice for peritoneal carcinomatosis. So it has two stages. The first one is the CRS or the cytoreductive surgery, where we remove any we remove all the visible disease in the abdominal cavity. Following this, we proceed to the HIPEC or hyperthermic intraperitoneal chemotherapy. Like the name suggests, it is the instillation of heated chemotherapy into the abdominal cavity for about 90 minutes. This heated chemotherapy destroys any residual microscopic disease in the abdominal cavity and the peritoneum. Because this chemotherapy is heated, the heat also helps with better penetration of the chemotherapeutic drugs into the peritoneum, which also enables better destruction of any microscopic tumor cells which are not visible to the naked eye. And also, because this is a localized instillation of chemotherapy, it can be administered in higher doses with minimal systemic side effects. CRS and HIPEC should be done in highly selected individuals because it's a major surgery and patients should be able to withstand the procedure. It could take anywhere between 6 to 12 hours for a procedure or even more. And also, it can only be done in patients where all gross or all visible disease can be completely removed from the abdominal cavity, and also disease which is only limited to the abdominal cavity. So CRS with HIPEC has also been shown to offer a long-term improved prognosis in these cancers. The other procedure that I was talking to you about called the PIPAC, this is pressurized intraperitoneal aerosol chemotherapy. This is done through a minimally invasive or laparoscopic approach where aerosolized chemotherapy is administered into the abdominal cavity under high pressures. This high pressure helps in penetration of the chemotherapeutic drugs into the peritoneum. And this can also be done in certain advanced cases, unlike the HIPEC, and this has a faster recovery compared to the HIPEC procedure. But this is not a procedure for to reach a completely cancer-free status. This procedure will help to reduce the disease load, and it could be repeated after a few weeks. And in cases or in patients who respond to this PIPAC, they may be future candidates for a CRS with HIPEC. The next thing that I would tell you about, next advancement that we have seen, is the advances in breast cancer surgery. So as many of you may be aware, breast cancer is the most common cancer in women worldwide and in India. And we are seeing a lot of young patients in 20s and 30s presenting to us with breast cancer, which is why It is very important to know more about this disease, and we have a lot of new advancements in the management of this cancer. So I will tell you about a few of these. Firstly, because of the increased awareness now and the increased screenings that are happening, we are picking up a lot of very early breast cancers which are not palpable, means they are not felt by us clinically. They are picked up only on imaging. So these cancers, how do we resect them? How do we remove them when we cannot feel them, right? So these cancers can be marked preoperatively by imaging. So we can either mark them with a clip uh, with an ultrasound guidance, and during surgery, using the same ultrasound guidance, we can identify where the clip and the tumor is and remove it. And post removal, the specimen can also be subjected to an imaging to ensure that we have completely removed the tumor with the clip. We can also use a wire guided localization where a wire is inserted into this non-palpable lesion. And during surgery, the wire guides us to the location of the tumor, which we remove. Another important procedure for these non-palpable lesions is what we call roll, or ROLL. Okay, so this is a radiocolloid occult localization of these lesions. Basically, a tracer is injected into the lesion, and using a probe, we can detect where exactly the lesion is during surgery and remove it. So this roll procedure is more effective than a wire guided localization. It accurately pinpoints to the location of this non-palpable tumor, and it also ensures that we remove it completely, and that we don't remove a lot of excess tissue, which can happen with a wire guided localization. So all the specimens which are removed like this, they should be confirmed post-operatively with an ultrasound to ensure that we have completely removed it. Okay. The next advancement that I will tell you about in breast cancer surgery is what we call oncoplasty. So in oncoplasty, we combine removal of the disease with reconstruction. That is cancer surgery along with plastic surgery in the same sitting. So we remove the tumor completely, and using the surrounding breast tissues, we do a reconstruction. This is called an oncoplastic surgery. There are certain procedures called skin sparing mastectomy or a nipple sparing mastectomy. These can be done when the tumor is away from the nipple areola complex and it is a very early cancer, or in certain high risk individuals who have a higher risk for breast cancer, they can have a prophylactic mastectomy. So the advantage of sparing the skin envelope or sparing the nipple areola complex along with the skin envelope is that it allows for a more contoured reconstruction and better aesthetic results. We can also do minimally invasive or robotic mastectomies, more commonly done in prophylactic mastectomies for high-risk individuals. Another important part of breast cancer management is the axillary staging. So we do what is called a sentinel lymph node biopsy. So this sentinel lymph node biopsy is done in very early cancers. Certain cancers tend to spread to the regional lymph nodes, and it is important for us to trace and to it is important for us to stage this regional lymph node basin as a part of the staging of the cancer. So in breast cancer, the tumors tend to spread to the axilla or the underarm area. So in very early breast cancers, which are, say, limited to the breast itself on preoperative imaging and clinical examination, there could still be microscopic spread to the lymph nodes in the axilla, which is what we try to detect through a sentinel lymph node biopsy. So in this, what we do is we inject a dye in the region of the breast tumor, and we trace this dye to the axilla, and we identify the sentinel lymph nodes. A sentinel lymph node is the first lymph node to which the tumor will probably spread. Once we identify the sentinel lymph node, we send it for frozen section analysis. So a frozen section analysis, the pathologist will look at this lymph node under the microscope and tell us if there is any microscopic spread to this lymph node. In case that there is no cancer in this lymph node, we will not proceed with a complete axillary lymph node dissection. So therefore, the sentinel lymph node is a minimally invasive technique compared to a complete axillary dissection, which is done in cases which are clinically node negative, and it also has fewer side effects compared to a axillary dissection, lesser chances of lymphedema, and also faster postoperative recovery period. Okay, another advancement in breast cancer surgery is what we call real-time imaging using certain dyes like the ICG dye. Here in real time, we can identify the tumor, the margin of the tumor using a fluorescence imaging, and we can accurately remove the tumor, especially in breast conservation surgeries, with clear margins. Okay, this is called real-time imaging of the breast tumor. Also, immediately post mastectomy or post removal of the tumor, we can go for immediate reconstructions of the breast, okay, which will help with better aesthetic outcome. So this is about breast cancer and the advancements that we have in this particular cancer. The next thing that I would like to inform you about is the ICG dye and the real-time fluorescence imaging, which I was just telling you about. This ICG dye has, initially it was used only for to assess the liver function. So this dye is basically, once we give it intravenously as an IV injection, it binds to the plasma proteins, and it tends to concentrate in tissues which have a high blood flow and which have limited lymphatic outflow. This is especially true in tumors. So this ICG dye is an near infrared fluorescent tracer, which means that once it is injected, we use a near infrared imaging specialized equipment. Okay, and on using this particular light, this dye will shine brightly. It will fluoresce. So we can make out the difference between the tumor and the normal tissue. So this ICG dye shows us the normal anatomy, especially the anatomy of the liver and the biliary tree. It shows us the vasculature, the lymphatics and the lymph nodes, and also the tumors. So it plays a vital role in oncosurgery currently. So how does it help us with cancer surgery, right? Firstly, it helps to demarcate the tumor margin. So a lot of tumors can have infiltrative margins, which means the margins are very ill-defined. We don't know where the tumor ends. So in such cases, this ICG dye, when given intravenously, can show us the margin of the tumor and help us remove the tumor with a very clear margin of normal tissue. So this is especially useful in breast cancer, like I earlier mentioned, especially when we are doing a breast conservation surgery, and also in rectal cancer. It can help us with mesorectal excisions, and especially in sarcomas and soft tissue sarcomas, they tend to have an infiltrative, ill-defined border. Their ICG plays an important role in delineating the tumor margin. And also in certain liver tumors, especially metastasis from the colorectal cancers. Another important use of this ICG in cancer surgery is it tends to collect inside tumors. So it helps us in identifying small, deep-seated tumors which we cannot see under the white light. So it will shine brightly inside these tumors, and we can differentiate between tumor and normal tissue. Okay, so especially in liver tumors, in primary liver tumors, in metastasis to the liver, especially deep-seated metastasis. So it helps us to remove the disease completely and also reduce the chances of recurrence by missing out on lesions. Okay. Another important use of ICG is in the sentinel lymph node biopsy, which I had earlier told you about, this is a minimally invasive staging of the lymph nodal basin. So this sentinel lymph node biopsy, other than in breast cancers, can also be done in a malignant melanoma, which is an aggressive skin cancer, and also in endometrial cancers and a few other cancers as well. So there are a few other dyes which we were using earlier, including a blue dye called methylene blue and a radiocolloid dye. However, ICG is better than these two dyes. Why? Because one, it does not emit any radiation. The second thing is because this ICG dye, once given around the tumor, can in real time be traced as it passes through the lymphatics to reach the sentinel lymph nodes. So it helps in very accurate detection of sentinel lymph nodes and is therefore better than the blue dye and maybe even equivalent to the radiocolloid dye. And it has very minimal side effects as well. Another important use of the ICG is in minimally invasive surgery, where it helps in identification of the tumor and also in delineating the lymphatics, and therefore minimizing the trauma to the surrounding structures. So it can be used in laparoscopic and robotic surgeries as well. And like I earlier told you, this ICG collects in areas which have a high blood flow. So this also helps us in cancer surgeries. In certain complex oncological procedures, such as in head and neck cancers and certain breast cancers, when we need to do reconstructions of huge defects, we will have large flaps, especially free flaps that we harvest from a distant site. And before we inset this flap, we can assess the blood flow of this flap and ensure that this flap has good blood flow throughout. In case a part of this reconstructed flap has lesser blood flow, we can make the necessary adjustments during the surgery itself. So this is very important because otherwise, when we just suture the flap to the recipient site, post-operatively, in case there is a lesser blood flow to certain part of the flap, there is a possibility that we may lose the flap. Flap necrosis can happen, and we may even have to take the patient for a second procedure to revise the flap. So all this is minimized by using an ICG intraoperatively to assess the vasculature and the blood flow of the flap. A similar concept is also used in bowel cancers. In GI or gastrointestinal bowel cancers, once we remove the tumor by a bowel resection, the two ends of the tumor are joined together in what we call an anastomosis. So ideally, the two ends should have a good blood flow for this anastomosis to heal well. If it does not heal well, or say the blood flow is not good, there is a possibility in the post-operative period to have an anastomotic leak. And that is a disastrous consequence and can cause severe complications in the post-operative period. So this ICG dye, when given intravenously, can in real time, we can check the blood flow of the bowel ends, and we can ensure that the two ends that we are joining together has a very good blood flow. This is especially useful in esophageal cancers. To do an esophagogastric anastomosis, we can assess the cut ends, and also in rectal cancers, we can assess the ends before we join them, limiting the post-operative anastomotic leak and complications. So this is about ICG. And finally, I will tell you about what we call a 3D printing. So a 3D printing is basically where we, a 3D printing of it is basically a personalized methodology for a patient, where we can print out the tumor, the surrounding structures, the vasculature in the preoperative period for adequate planning, especially in complex procedures. We can assess the tumor and the margin that needs to be given, etc. preoperatively itself with these 3D printed models. And this can reduce the intraoperative risk and the intraoperative time taken for the procedure. And also, it helps us intraoperatively for accurate resection of the tumor because it has already been planned very well in advance. There are also 3D printed implants which can be fit into the defect caused by this removal of the tumor, especially in complex anatomical areas, and helps in better reconstructions. So this 3D printing helps us with accurate surgical planning, precise resection of tumors, and ensuring accurate reconstructions, which can improve the quality of life of the patient, also reducing the post-operative complications. So as you can see, I have listed out several new advancements that have come up in surgical oncology, and surgical oncology is constantly developing. And now we have AI in surgery, we have molecular profiling, which helps in personalized treatment to each patient depending on the tumor biology. And we also have what we call a sentinel node navigational surgery, which is basically a minimally invasive clearance of the lymph nodal station. All these are slowly being incorporated into surgical oncology, and they are still being researched in depth, and it will just get better and better from here. So basically the intent is now to adequately stage the patient and plan ahead and do a complete precise removal of the tumor with minimal trauma to surrounding tissues, including minimally invasive approaches, and ensuring that the patient's post-operative quality of life is good, both functional as well as psychological. So I hope you have enjoyed this live session. Thank you so much for staying with me.